Welcome, Vatech family, to another edition of the Vatech Weekly Webinar Series. This is the May 6th edition. This happens to be our 6th broadcast in the series. We are live every Wednesday, noon Eastern Daylight Time. I am Jim Mayer, Education Team Manager with Vatech, broadcasting live here from my home office in St. Louis, Missouri. As always, I have the pleasure of working with Paul Satone, who is broadcasting live out in Las Vegas. Good morning, Paul.
Hey, Jim, how are you? Great to be back. Last week we had a great session with Dr. Miles, focused a little bit more on 2D, and this week we get to really dive into 3D anatomy, so I'm really excited about this presentation. And then also we have, for all the attendees, we have a CE credit, so that's a great bonus this week.
For sure, yeah, some added things there. Really excited about bringing Dr. Dale Miles on today. Last week after the session, we did send out a poll and kind of priming everybody for upcoming sessions that we're thinking about doing, and also thinking about when we're all going to get back to work and getting back to our office. And the question we asked and got some really good feedback was involving our staff in the CBCT technology and understanding the data in order for our staff members to discuss that with our patients. And Paul, what was the feedback and what were the numbers on that poll that we sent out last week?
Yeah, so from our polling from last week's webinar, we got about an 80%, we did get 80% results of yes on the topic of educating staff members further on CBCT technology, specifically with patient focus in mind. So our goal is to implement some of that into some of these future webinars. So thank you for the feedback.
For sure, yeah, thanks everybody there. Coming up, May 13th, session 7, directly relating to that. Paul, you want to talk about our complete health dentistry topic and basically the dental paradigm shift of
Sure.
the new normal, if you will?
Sure. So next week, May 13th, we have complete health dentistry with Gary Cady, who's the author of $1 Million Dentistry. So we'll be discussing the new patient in these new times that we're kind of entering and how they will relate to dentistry. We'll talk about educating patients. We'll talk about empowering team members. We'll look at some of the new cutting-edge technology that's that is and future standard of care. We'll be reviewing case studies, and then we're also going to dive a little bit into the Vatech Ez3D-i software in relation to all those topics. So that'll be interesting on that one. On the 20th, we'll have guided surgery workflow. We're calling it the tour of the guided digital implant workflow from start to finish. So that'll be a great session as well. And then future sessions, again, feedback is greatly appreciated on any topics that you would like to see us kind of talk about and review.
For sure, Paul. Yeah, you and I have been talking about, and our education team really, and Vatech as a whole, have been talking about doing a reoccurring webinar series. I know we've been doing a lot of webinar series, but everybody's going to be getting back to work soon. And
Right.
What can we bring as an added value for our Vatech family? And Paul, here's some of the ideas if we would talk about if you want to kind of discuss those and give us a little highlight.
Yeah, so me and Jim have kind of been tossing around ideas, full transparency on things that may be of value in the future going forward, when we're all kind of back to work or quote unquote back to normal. We might have monthly webinars or bi-weekly, or we haven't really figured it out yet, but webinars for staff or doctors, for the 3D-i software, the beginner, advanced, intermediate tips and tricks. So really looking to kind of take this and move it into the next phase, so to speak. So again, feedback is really, really appreciated, and thank you for that. As far as feedback goes, we have a couple different ways to communicate. Again, sales@vatechamerica.com for any feedback about this or any other webinars you'd like to see. Our education team, anything software related question wise, please feel free to email us education@vatechamerica.com. And customer support, great way to contact support, especially if you're busy, you don't have time to call, is just shoot them an email, and that's cs@vatechamerica.com. We have our web address, vatechamerica.com, and then of course you can always contact us on Facebook, Instagram, and LinkedIn with the handle of Vatech America. So a lot of different ways to contact us.
For sure. Before we bring Dr. Miles up here, let's talk about what we're seeing on our GoToWebinar session here. You do have your screen of the video at the top. Paul and myself will bring Dr. Miles up here soon. You'll be able to see his screen. Off to the right, you have your little orange arrow, which is just the navigation toolbar for your GoToMeeting. If anyone's having audio issues, I would recommend calling in on the phone, or if you are using your computer audio, go ahead and click on the help icon over here, and that will allow you to troubleshoot your own onboard computer audio there. This is a question and answer session, so we will have direct access to Dr. Miles. He'll be doing a Q&A with us. To ask a question to Dr. Miles or the Vatech education team, please go ahead and type your question in down here. Our staff, full education team, is standing by to live interact with you to answer those questions. Immediately following the presentation from 1 to 1:30, we're going to have the Q&A with Dr. Miles. Today, May 6th, Paul talked about last week, we looked more at 2D and a little bit of 3D. Today, Dr. Miles has got a great presentation recognizing and identifying relevant structures or anatomical structures in the Vatech, in the basically cone beam technology or 3D software. You will be getting CE credit for that, and we're going to discuss that at the conclusion of today's session. So please stick around to the end for more information on the CE that will be provided. With that, I would like to bring up Dr. Dale Miles. He is a diplomat of the American Board of Oral and Maxillofacial Radiology, also diplomat of the American Board of Oral Medicine. He's held academic positions at several dental schools, including Connecticut, Indiana, Kentucky, Arizona, Texas. Dr. Miles, welcome.
Good morning, Jim. Good morning, Paul.
Morning, doctor.
Good to be back. You guys get me up real early to get in here to the facility so I can do this, but I'm happy to be here. I wore my mask into Dr. McClammy's office. This is where I'm located in Scottsdale, Arizona, because he has patients, so out of respect, for this particular pandemic, I wore my mask and my scrubs in here today. I look like I belong in the office today, at least anyway.
Well, we are very thankful that Dr. McClammy is allowing us to use his office, and also thank you for getting up early and joining us there. We're really excited about your presentation today. What I'm going to do is I'm going to go ahead and share over to you and make you the presenter there. So you should be able to go ahead and show your screen there. All right.
Okay, well, I got to shrink you guys down. You always populate my screen so I can't see my titles. So. Good morning to everyone out there. Thank you for logging in and coming to see this particular webinar. I've got a number of these programs, and possibly in the future, we might even see another one of these with our Vatech hosts. So this particular webinar is basically the 3 planes of section, and I'm trying to pick out planes of section at different levels that have at least some recognizable structures, and then we'll work out from there. So we're going to do a number of things. Jim, if you could go ahead and take me off the webcam there, I'll start, okay? So the objectives for this particular session are to identify structures to help you review your images, visualize anatomic detail in 2D and 3D. There we go, thank you. And understand the importance of reviewing all the slice data. So I've peppered this presentation with some examples of why you need to be looking beyond some of the dental structures that have your more focused interest in. We'll show you those as we go along. So we're going to review axial slices, sagittal and coronal. Those are traditionally referred to as the MPR slices, the multiplanar reformatted slices. We're also going to see what we call 3D slab renderings. It could be in color or it can be in grayscale as well. And they're very easy to do in software like Ez3D-i. They're easy to do in some other third-party softwares as well. And people don't think about thickening the slices to identify anatomy or pathology. Mostly everyone's interested in, oh, I need the thinnest grayscale slice possible, but that's not always diagnostically useful for you. And we're also going to show you what 3D color reconstructions look like. So the first image that I brought up is an axial slice. It actually happens to be going sort of midway through the condylar head. You can see the right condyle over here, the left over here. Cone beams, as I told everybody last week, they don't come with arrows, okay? We put those on, but hopefully, just looking at this slice, you'd be able to recognize that the maxillary sinuses are present bilaterally. And oh, by the way, they're full of material, okay? This is mucosal change in some of the reports. This could be related to hay fever, allergies, asthma infections, dental infections, you name it. So there is anatomy in here that you'll know right off the bat. Some of it you won't, and that's hopefully by the end of the session we'll have a better handle on all of this anatomy. I'm showing you the patient's right lateral pterygoid plate, and this is the patient's left lateral pterygoid plate. On occasion, you can actually see the fascial planes surrounding the musculature. In fact, this one is outlined reasonably well. This is the inferior belly of the lateral pterygoid inserting into the condylar head from the lateral pterygoid plate. Hopefully you'll also recognize the mastoid processes, but after that, for many dentists, it's a, if you pardon the expression, it's a crapshoot, okay? Here's the sagittal plane of section. You can recognize the nose, you can see some teeth. Hopefully you'd recognize this canal. This is the nasopalatine canal running from the nasal cavity to the palate. The opening would be the nasopalatine foramen. If you see this and you see spinal column, you can see the spinal areas here, then basically you know you're pretty well in the midline from left to right within the patient's body. Other structures, this big old black space up here is the sphenoid sinus. This area here is the frontal sinus. There's a little division into chambers here. And here's the sella turcica where the pituitary gland sits. So we're going to go through all these structures. We won't go through them rapidly. We'll take our time. Some people will look at their smaller fields of view and say, well, I don't need to know all of these structures up by the sella turcica or the spine or the airway, you know, ethmoid air cell complex, because I have a small field of view. This would represent an 8x8 field of view and a comparable one, I'm sure, in the Vatech machines. And this would be taken for dental alveolar volume for doing implant planning or looking at the dentition for endodontic problems or missing teeth or whatever. But if you move that volume back to capture or center a third molar that you were concerned about or that was impacted and you wanted to trace the nerve, when you move it back, you can see that that volume now picks up the entire airway, the hyoid bone down here, parts of the spine. So you have more responsibility to look at that area. And if you don't know your anatomy, you won't pick up the pathology. By the way, interesting, there's a supernumerary tooth developing way out here in the buccal aspect, preventing 16, or for our international colleagues, 2-8 from erupting. And you know, your buccal object rule and all those other things we taught you in dental school go away when you have a 3D rendering. So you can just find it. Now, for those of you who say, well, I got a small volume, I'm not going to see the sphenoid sinus ever. Yes, you are, because when you move that volume around to take the temporomandibular joint condyle to see if, you know, why the patient's having pain, of course you're going to be up there. So I superimposed a thin slice sagittal reconstructed view of the condylar head. And in there, condylar head, articular eminence, external auditory canal, and the mastoid air cells again. In 3D, you can actually see what's going on. So in the 3D rendering, we see a small osteophyte. Actually, this is called lipping, and it'll be occurring probably along the length of the condylar head in there. So you have ways of looking at this data, thin slice, color surface renderings, and moving your volume around so that you can see everything. But of course, that means you have to know a lot of your anatomy, and most of you are relearning it on the fly. So here's a coronal plane of section. It's midway through the molar region. You can see that the nasal cavity structures in here. These are the inferior turbinates. These are the middle turbinates. They have an aerated area within them, which is an anomaly called concha bullosa, which we'll come to later on in our series. The septum is deviated slightly to the right. These are the ethmoid air cells, and the ethmoid air cells actually communicate with the frontal sinus bilateral recess a little further back posterior. So you need to really understand the nasal cavity structures as well. So there's the inferior turbinate, middle turbinate, and there's an ethmoid air cell up in the superior ethmoid air cell complex. That, of course, is your eyeball. Okay, that's the globe, and you can see it outlined here. You can see soft tissue in many of these scans. You just don't see it as detailed as in conventional CT. A slab rendering, you can look over here in the upper right. You can see this says 25.9 millimeters. We would start out in maybe thickening the slice, changing it to a MIP image, a maximum intensity projection, which is again very easy to do in the Vatech software. And then I colorized it. I picked a template. I spent a lot of my life making these colored templates up for other manufacturers, and so some of these will be in similar ones will be in the software that you're using. So a slab rendering at 25 millimeters shows up a lot of stuff. You can see the condyle nestled in the fossa. This is actually the foramen spinosum right here and the foramen ovalis. So the skull base is very understandable. This is the opening for the internal carotid artery on each side. We'll go over those again in thin section. That you could have a thickened grayscale slice by hitting some of the options in the tool panel in the Vatech software. This is a full 3D color surface rendering, which I think last week I told you I use this quite a bit for just alveolar crestal bone levels. You can rotate this in 360 degrees. You can click on icons to look from left, right, obliquely from the side. So there's a lot of options. So let's go to the, excuse me, the axial sections. This is a section right through the condylar heads, and there's some important structures to identify in here. So what I suggest you do when you're first learning this is identify a structure you know, like the condyle, and then move away from that, to something adjacent. If you go behind the condyle, you'll see a little opening. Well, this is the external auditory canal, and this will be the internal auditory canal. And sometimes you'll see the little ossicles within here. So the EAM will show, as you move to another region behind the external auditory canal or meatus, you can see the mastoid air cells. So those structures should be very familiar to you. What isn't familiar in these kinds of planes of section are some of these openings in the floor. This happens to be the jugular opening for the jugular canal, and there's the carotid canal. And here's the lateral pterygoid plate in this patient. So you need to study this, and this series is being recorded. When you revisit, or those of you who register and come later and visit, you'll be able to watch me disclose these structures. And 2 or 3 times through this particular webinar, you should have all your anatomy down pretty pat. So A is pointing to the soft tissue of the nose, okay? B is just pointing to one of the turbinates. Now they don't look like they did in the coronal section. They're going from anterior to posterior. And these are probably middle turbinates, sort of partway through them because of where we are in the maxillary sinus. C, I already showed you in the previous one, is the lateral pterygoid plate. D, I'm going to drum these into your head because these, along the length of this canal, when it comes upward towards the sphenoid sinus, I see plaques and medial arterial calcifications. I see things that you need to recognize and have a referral made to the primary care provider. So this is the opening for the internal carotid artery. Okay. This is the external auditory canal, as we told you earlier. F is the mastoid air cell region. G, the carotid artery and the jugular vein travel together, and you can see that the jugular canal is right there. The condyle, you shouldn't miss that. If you miss that, you have to leave the seminar and go get a book and study some more on your own. Just kidding, guys. But everyone recognizes the condyles usually in these views. I is actually trying to point to the inferior belly of the lateral pterygoid again. This was a pretty good example. I shouldn't have put my arrow right into it, but it's not a bad example of and you can see a minor fascial plane here. And J, if this is the condyle, there's a dip as you go anteriorly, and there's another process, and that is the coronoid process. This is where the temporalis muscle insertion is, one of the prime elevators for the jaw. So there's a lot going on in there, just in that one slice. So there's our inferior belly of the lateral pterygoid outlined for you. In this particular one, I'm just gonna, I usually have you recite this when I do this live, and I'll say, okay, what's this? And the audience goes, condyle, mastoid air cells, coronoid process, lateral pterygoid plate, carotid canal, jugular vein canal, maxillary sinus, nasal septum. These are common structures that you should know. These structures where the vessels are in the region at the skull base is going to become important to you because of the systemic things that we see in those regions. So when you review this, these are all labeled up for you. Some people might even want to take a screenshot of that. If you're really interested in learning the anatomy, you can actually purchase the Scanatomy app off the Apple website, which I put up there some years ago, and is an inexpensive way of reviewing all of your anatomy in the 3 planes of section. So now we have a plane of section, an axial plane that's a little bit higher up. You can see that the patient's left maxillary sinus has some significant change in it. You can see the condyles. You can see the foramen ovale, foramen spinosum. But there's other structures, and I'm going to go over them for you. So A, mastoid, B, condyle, C is the zygomatic arch portion, D is pointing actually to a portion of the eyeball, okay, just the inferior portion at this point. E is pointing to the nasal septum. F is pointing to the foramen ovale. When I have an audience, I'll say, well, this is one of the foramina that you learned of the cranial nerves, and it's kind of oval in shape. What do you think it is? And everybody guesses foramen ovale. G, I'll say this is either rotundum or spinosum. And I'll ask, how many say rotundum? And half the audience puts their hand up. How many say spinosum? Half the audience puts their hand up. But this is where the 7th cranial nerve comes in, and basically, this is 5 and 7 traveling together. I is actually the opening, a small inferior opening for the sphenoid sinus. The sphenoid bone is this great big thing here. J, foramen ovale on the opposite side. K is the external auditory canal, and I skipped over H, but this is important. Carotid canal comes up here. It runs along and upward the base of the skull to come to a groove in the sphenoid bone, which we'll show you in a little bit. And it's right in there that I see a lot of the calcifications, especially in patients who are diabetic, either undiagnosed or uncontrolled. We go way far down now in the neck. You can see lots of soft tissue, even though the vendors early on used to tell us, oh, you don't see soft tissue in cone beam, don't worry about it. Well, yeah, you do. It depends on the quality of the image. But I'm going to go over these structures fairly quickly. There's a large, flat, gray, linear shape here. We used to reflect it when we did our anatomical dissection, and that is the platysma. Plat is the word for flat in French, and it was a very flat muscle that we reflected. Number 2 is pointing to one of these 2 muscles in the floor of the mouth. If we could see the mandible, we'd be in the genial tubercle region a little higher up. And this muscle, especially on the patient's left, you can see travels all the way to this structure, which everybody will recognize as the hyoid. So this will be the geniohyoid muscle. So 2 is the geniohyoid muscle. Maybe the patient was swallowing or contracting something, but anyway, you can see that it goes from this genial region to the hyoid bone. Carrying on with muscles, this is when you palpate your muscles of mastication, and you go and have the patient turn their head to the side and palpate the SCM. This is the body of the sternocleidomastoid muscle. Behind it, which is a very large muscle, but our volume cutoff is actually the trapezius. So these 2 muscles have fibers that communicate one with the other, join, so that you can turn your head and scrunch your neck up and do all those fun things. Number 5 is the hyoid, like I said. Number 6 is just the pharyngeal airway, and it's at the level of the hyoid going down. So this is the pharyngeal airway, not the oral pharyngeal. That would be a little higher up. 7 is pointing, I don't expect anybody to get this, but we're looking at the external jugular vein. Okay. 8 is the body of C4 because we're so far down. This is vertebral body. Out to the lateral aspect are the other portions of the spine. These are the facet joint regions on each side. So spinous process at the back, and this is towards the lateral process, and this is called the articular pillar. And this will be communicating with the joint above and or below. Number 10 is actually the internal jugular vein. Again, I don't expect you to know those, but they do stand out so that you can, sort of guess at vessel or think about a lymph node, because sometimes lymph nodes will show up like that as well. 11 is pointing to a roundish kind of structure. There's 2, they're sort of underneath the hyoid bone, and these are actually the submandibular salivary glands bilaterally. And sometimes I'll see one enlarged relative to the other, so there might be some type of salivary gland problem. As we come a little higher up, how do I know? Because there's the anterior portion of the mandible. Okay, we can see some other structures that we know. The second one here, this little curved area is, of course, the epiglottis. This is a vertebral body. I don't know which one, but probably C3 or C4. Again, C3 it says here. I already told you that the posterior portion of these vertebral bodies is called the spinous process, and they slope downward slightly as you see them in a sagittal view. Again, the articular process and the pillar area for C2. And this last one is actually just pointing to the submandibular salivary gland. I should have had it outlined first. You can see some soft tissue outline here. Okay, so this is, even though it's a little higher up, we can still see the gland on each side. And I see calcifications within there. I see lots of salivary stones in the duct leading from that gland. So again, structures you need to know. Some of you are focusing on this big black hole in the vertebral body. This is probably just a subchondral cyst or could be an erosion. We'd have to see it in another plane of section. However, the spine is a good place for metastatic lesions. So if you have a history of cancer or any type of remote lesion, cancerous lesion, the vertebral column is a good place for mets. We come a little bit higher up. How do I know? Well, we can see the maxillary dentition here, but we also see the mandible. And having said that, that helps me lead you to the next structures. There is the 5th cranial nerve comes out of the base of the skull and goes into the mandible in the posterior region, and that is into the mandibular foramen, not the mental, but the mandibular foramen. The little area protecting it, this little bony protrusion, is called the lingula. We'll see that in a second. Number 2, we're out here in the spinal area again, and this is actually, this whole area that I'm outlining is actually a portion of C1, okay, atlas, and it is a big vertebral body. We're seeing it inferior to the second vertebral body, which we'll see here in a second, but it actually has a completed kind of arch in it on the anterior part if we were to go a little higher up. Number 2 is the transverse process. Number 3 is the pedicle again, and this is of C1. 4 is the posterior arch of C1. When I show you this a little later on in 3D color, it becomes very understandable. The atlantoaxial junction, this being atlas, okay, and C2 being axis, this portion being the dens portion, it becomes clearer in 3D. There is within all these vertebral bodies a passageway for the vertebral artery. So this is the foramen for the vertebral artery, and it actually comes inward towards the foramen magnum a little higher up and then goes up to the skull. 6, I already told you, was the dens or the odontoid process of C2. And I see calcifications, especially in the region between the anterior arch of C1 and the dens, which are loose bodies, just like you see in the temporomandibular joint complex region. 7, believe it or not, is a portion of the styloid process. It starts out up by the mastoid and goes down to the stylohyoid region. And it can look like a small dot, a big dot, and it goes medially on each side. You'll see these dots at different levels. 8 is pointing to the masseter muscle. The lingula I already showed you, so it will outline the masseter muscle right here. And then 10 is pointing to a tooth. If you can't figure out that that's the palatal root of, the second molar, number 15, again, just go home now. Just kidding, guys. Okay. And 11 is not quite outlining, but this is where the nasopalatine foramen would be, which some of us learned as the incisive foramen because it's behind the incisors, but nasopalatine is more correct. So on here, what I've done is gone just a little bit of, just made a little bit of separation so you can see the anterior arch of C1. You can see the dens portion here as well. And what I did was I put in little red circles to show where the vertebral arteries would come up. Okay, those are the foramina. There's, again, anterior arch of C1, and there's C2, the dens portion. So that's important. Well, why is that important? Because periodically in that region, I'll see things like this. These are actually vessels. These are vertebral arteries that have calcification around the medial layer, not the tunica intima, not intimal plaques, but calcifications in the muscular layer or the medial layer. This is a diabetic or someone with kidney disease or any of those other comorbidities. And if you've not been introduced to it, you're never going to find it. You'll look at it, go, that's probably just normal, and skip on from there. So we're going to teach you here and in some of the other series, if we get to them, much more about the various systemic findings you have on these scans. I made this a little bit bigger so that you can see it. You said, well, I'm not going to see those. I have a small. No, you're going to see them if you have a condyle in the view, because even if it's a 4x4, it'll come back to this region. So those are called medial arterial calcifications, and they're seen in type 2 diabetes mellitus. And no one out there has a diabetic patient in their practice, do they? Okay, you're supposed to be laughing now. Of course you do. You see them every week. All right, so to give you a schematic of what we were just looking at, this is C1, okay? This is C2, the dens is peaking up beyond that. And you can see how the vertebral artery comes through all of these lateral processes. And then right here, there's an opening in C2 called the arcuate foramen. You don't have to know that, but it pins out and goes up through the this portion of C1 so that you don't impinge when you turn your head, because remember, this vertebral body rotates, helps you rotate your head, and you don't want this artery impinging on it, so or the bone impinging on the artery. So we're put together pretty nicely by whoever put us together. All right, so here's a slab rendering. Again, I did it at about 27 millimeters, and this is the same patient we've been looking at. This is the C1, okay, vertebral body C1. This is the dens portion of C2. You can see the condylar head on this side. We cut off right at the neck. We can see the mastoid air cell process. This would be the carotid canal here. This is the foramen ovale here, and this would be spinosum. So just by making a 3D color image of the base of the skull, if you're looking at an axial view and you're getting lost or you don't know what structures you're looking at, we can very easily look at these structures in 3D. Nice tool in Ez3D-i is the MIP tool. We demonstrated it last week briefly, but if you see a circular or curvilinear calcification unilaterally, bilaterally in the neck region, okay, this is a carotid calcification. Now, it is not a plaque. It is, again, in the medial layer, the tunica media. This is medial arterial calcification signaling diabetes. And they may know about it or they may not. And you can easily ask questions in your practice that relate to, the diagnosis of diabetes. You can send them off to their primary care provider for simple serology and a urine test. And you can look in other portions of your cone beam volume, and if you see some other rounded, circular, curvilinear, or parallel line kind of calcification, you probably should be very diligent in pursuing the diagnosis of diabetes. In this particular case, we were able to open up the toolbox. Okay, to make this more prevalent, we used that MIP image, the MIP image. So we thickened it to 10 millimeters, and then we open up the toolbox and click on the MIP tool over here. And your folks from Vatech can show you how to do that, but look how nice that calcification stands out. If someone were to do a cervical ultrasound, okay, of this region, they could be misinterpreted as a simple plaque, and they'd say, oh yeah, you got arteriosclerosis, we got to do an endarterectomy and roto-root your carotid there. But this in particular is not related to arteriosclerosis. It's more related to diabetes. All right. Here it is in the coronal plane of section. I should have made this image bigger. Normally I make the image fill the screen when I'm looking at it and scrolling through. But you can see how, even though it looks like a big lump, you can see some parallelism. These are calcifications within the walls of the artery and probably around the anterior portion or the posterior portion. So again, medial arterial calcification on the patient's right cervical segment. We don't have the sellar region because that's the other place we see them. And just because it's unilateral doesn't mean it can't be systemic. So you need to check those out. Still staying in axial, which is the most, it's the most difficult planes of section to understand when you're first looking at cone beam, because we never saw patients cut up like this before. Sagittal and coronal are much more understandable, but in this sagittal plane of section, we're now a little bit up in the mid portion of the palate. You can see one is the anterior nasal spine, two is a torus. This is what they look like, a palatal torus. They take all kinds of shapes, and you'd see them in the other planes of section. Three, this is a very short lateral pterygoid plate. We might be up near the top of it, but this is the lateral pterygoid plate. Four is basically the body of the mandible just below the ramus or the condylar neck. Five is the outline of your ear. This must be Vincent van Gogh, right? See, he's only got one, never mind. This is the soft tissue outline of the ear. Six is a little tiny piece of that styloid process again. Seven, the dens or odontoid process. Eight, tip of the mastoid air cell process. So this patient is either a little asymmetrical or they've been acquired with their head tipped a little bit. But as you scrolled up and down, you would identify these other structures very easily. Nine is the inferior belly of the lateral pterygoid again. 10 is maxillary sinus. 11 is the nasopalatine foramen. So this is a plane of section you'll see frequently and should recognize all these structures in the axial plane of view. This is a little bit more complex. This particular level, we're up high in the maxillary sinuses. I don't see the soft tissue of the nose, but that's what it was sort of, should have seen the soft tissue, and we could have seen the nasal fossa itself. 2 is one of the turbinates, okay? In this case, we've labeled it middle turbinate, but again, we're higher up, so it gets a little bit smaller, a little bit narrower. This whole area that I'm outlining is the sphenoid bone. Okay, and the sphenoid bone, if you're right in the middle of it, that's just the body of the sphenoid bone. Number 4, zygomatic arch, again, 5, condyle. 6, I only labeled it, I haven't seen any pathology related, but it really is a fissure, okay, and it's from the petrous portion of the sphenoid bone to the occipital region. Right in here, we'd have the occipital condyles a little bit lower down. So this is the petrooccipital fissure. Again, I don't care if you know that, but you should be curious enough to look at those areas and maybe say, is that pathology or is that normal? Well, in this case, it's just normal. Above that, we can see the foramen ovale and spinosum again. And 7, of course, is the carotid canal. 8 mastoids, 9 external auditory canal. 10 is the petrous portion of the temporal bone. The temporal bone is linked to the sphenoid bone. The temporal bone houses the TMJ complex. You need to know this area. This region, in a neuroradiologist's world, they can take a 4 by 4 centimeter field of view and identify 70 anatomic structures just in the middle ear region. So we're not going to delve into that deeply. I don't have the expertise to walk you through that, but trust me, this is a protocol. The temporal bone protocol is very common in the head and neck radiology world, especially in neuroradiology, because of all the problems patients have with ears and balance and other problems. So 10 is the Peters portion of the temporal bone. 11, this doesn't show it. I didn't capture it, but I was trying to show the muscle just as it would be around the coronoid process, but I wasn't able to show it. I'm sorry. 12, of course, is the nasal septum, and it has a deviation towards the patient's left. And this is a portion of the sphenoid sinus, again, within the sphenoid bone. I know I'm going rapidly. Some of you will want to review this, and I think it would be a good idea if you did, because these structures are all very important. The yellow arrow is pointing to ovale. The green arrow is pointing to spinosum. We'll see rotundum later on in the coronal planes dissection. Boy, this time is going quickly this morning, and I got to get rolling. So 1 is the nasal septum. 2 is some schmutz. It's some mucosal change within the ethmoid air cell complex. That's all of this region. 3 is actually the pterygopalatine fossa. You can see it here and here. Kind of almost looks like the optic canal region, but it's a little lower down. 4 is pointing to the malleus, the head of the malleus. And I can show you the malleus and incus a little bit later on. The cochlea is this little curvilinear structure here. You can see it on this side as well. We see semilunar canals and cochlear turns in these regions. Again, you don't have to diagnose it, but if this was blasted away and the bone was missing, you might want to get a referral. This is the groove for the carotid artery in the sphenoid bone, here and here. Very important region. I see calcifications in there at different levels all the way up and down the slices. So that's the groove in the sphenoid for the carotid. That is the sphenoid sinus. And this is a normal patent ethmoid air cell. All right, don't worry, we go quicker through sagittal and coronal. All right, so 1, we're looking at the globe or the eyeball. That makes this structure coming into it, the optic nerve. This is the posterior clinoid process. These are the anterior clinoid process structures, and the pituitary is right there, the pituitary fossa or the sella turcica. So this structure is important because, again, those arteries that I told you about, the internal carotid, you'll actually see them with calcifications in them that are MAC, the medial arterial calcification in diabetics. I'll show you an example a little later on. The optic canal is here, and this is why the optic nerve is, and this is the optic chiasm. So this is where your visual nerves cross, so we can see in a stereoscopic manner. Number 7, ethmoid air cells again. So what's important? Well, we just saw the pituitary region. We are now recognizing that this is part of the sphenoid sinus and ethmoid air cell complex. As we look in the pituitary fossa, we see little tiny calcifications. That's not normal. When we see calcifications in thin section, we do a MIP image. We try and make them stand out a little bit more. This wasn't real definitive, but you can see 2 or 3 calcifications within the pituitary fossa, the sella turcica. And when we turned it on in a sagittal view and did a MIP image, you can see lots of calcifications. This is a pituitary tumor. This is not just bone or scatter artifact or other problem. If you see these kinds of disturbances within the pituitary, it's an adenoma. Could be benign or malignant. And if you miss it, you're in trouble. There are lots of hormonal secretions that the pituitary manufactures, so there will be usually clinical signs or symptoms, and it behooves you to study up on some of that as well. This is a calcification, a physiologic one in the pineal gland or pineal gland, and it's normal. It's only abnormal if it gets to be bigger than a centimeter. So pituitary tumor, here it is in a coronal planar section. These are the clinoid processes. This is tumor. And you can see the condyles. So if you go up to get the condyles, you will catch that region. So this is a schematic that I put in here. I showed you this image earlier, but this is the typical 4x4 image, 4x4 centimeters. Some people that just do, I only do the temporomandibular joint. I'm an expert in that. They need to really understand all the anatomy around it and look at the important structures. Ovale, spinosum, carotid canal, all the ossicles within here. The eustachian tube is there as well. So I'm not going to go over those again. They were in the previous image, but that's, even if you have a small field of view, depending on where you place it, there are important structures. So this is a slab rendering showing the same thing. Condyle, zygomatical temporal suture, coronoid process. You can see we've labeled over here lateral pterygoid plate, carotid canal again, foramen magnum. When you make a 3D image, you'll start to understand better the anatomy in your scan. And there's the region we've been looking at. I won't spend any time on this. You can review it and take a look at it when you go back to the Vatech site, to the webinar, but it's just a little thicker slice with more structures. Sagittal views. The sagittal view is important. It's understandable. This is how we see most of our patients. But this is a young patient. They have mucosal change in the frontal sinus, the ethmoid air cell complex. They have enlarged adenoid tissues. They could have an adenoiditis. They could have a sinusitis. They also have a little circular area in here, much too young to be an osteoarthritic change, but that's what it looked like, a subchondral cyst. So let's name structures. B is the frontal sinus. C is the pituitary fossa or the sella turcica. This is part of the sphenoid bone. As you get this slope area down towards the spinal column, this is called clivus, okay? It just means slope in Latin. And it's part of the sphenoid. There are calcifications that will occur in this region that you need to identify on occasion because the patient may have neck pain and referred pain. So D is clivus, E is the hard palate, F is the anterior arch of C1, and remember I showed you how big that was. I'll show you again in a second. G is vertebral body C2. It's quite long. The top portion is called the odontoid process or the dens. H is a spinous process. J is the epiglottis. It's kind of stuck up against the posterior part of the tongue and pharyngeal wall. I is the hyoid bone. When we come a little more laterally, you'll see structures that you recognize, of course. Number 1 is the condyle. Number 2 is the articular eminence. Some people take closed and open views to, map the translation or not. Number 3, we're way out on the side, but this is actually just part of the maxillary sinus. It looks unusual because we're way out on the lateral aspect, because we're at the condylar head. Of course, this is the eyeball up here. 6 is pointing to the external auditory canal. Sorry, 5 is inferior alveolar canal. 6 is pointing to the external auditory canal. This is the mastoid air cell region, and this is malleus and incus. Okay. If you look here closely, this is the malleus on top, the incus coming down. On occasion, you can actually see the stapes, and it's right in the field of view of the condyle. A lot of times we see some wax buildup in there called cerumen, and it's one of the prime causes of hearing loss. So in this particular case, I'll just bring these up. A, mastoid air cells. B, external auditory canal. C is the petrotympanic fissure. I don't care if you know that, but it's how we radiologists used to know we're in the middle of the glenoid fossa. We look for that landmark. So C is called the petrotympanic fissure. D is the inferior alveolar nerve canal. E is sinus. F is globe, the eyeball, big deal. Okay, G is the malleus and incus again. H is the articular eminence. I is some cerumen. They may have some hearing loss. They may be on their way to getting a problem of a middle ear infection. So, important that if they're complaining about ear pain, that you send them off to the otolaryngologist to rule out some simple reasons. And J, of course, is the maxillary sinus. This is a coronal section deep in the back of the skull. You can see these are this is actually the cochleal turn on each side. There's the head of the malleus. I was able to, in the software, just click on that malleus, drag out a circle, and I get the 3D image. So you're looking inside the internal auditory canal at the head of the malleus and the incus. Again, I don't see the stapes. So this is condyle, okay, right there. That's the incus and malleus. And we can see them in 3D color. These I won't disclose, we'll just go over it. You know, when the orthodontists measure SNA, SNB, well, there's nasion right there, that little kind of sharp angle. And this is the nasal bone. It's actually two flat bones paired in the midline. Frontal sinus region, ethmoid air cells, sphenoid sinus region with some septal areas in it, sella turcica or the pituitary fossa. You're looking at enlarged adenoid tissues again, clivus, C2, anterior arch of C1, uvula coming down here and soft palate. The tongue is just this whole big area here, and you can see the epiglottis sticking to the back of the throat again. You can look at them in 3D color. We saw this earlier without any of the markings on it, but you can make a 3D image to look at it. One of the important things to remember is that, and it's very uncommon to have Eagle's syndrome. It is a syndrome. It's not just the calcifications that you see of the styloid process. Syndromes also go along with, you know, signs and symptoms. So if they have a fishbone feeling or pain on swallowing that's neuralgic in nature and they have an elongated calcified process, they could have Eagle's. The stylohyoid ligament complex actually has 4 segments to it. I showed you this one last week, and all segments are calcified bilaterally with this patient. And you can see a much larger image here, right from the styloid process down to the hyoid bone. Now, one of the things that you'll need to understand is that the thyroid cartilage down in here actually hangs or suspended from the hyoid by ligaments. So you'll see on your sagittal views the superior horn of the thyroid cartilage, and it'll be calcified, and even the ligament can calcify. But in sagittal, you'll recognize a part of the hyoid. Here we're looking at the lesser cornu, the yellow arrow here and here, and then superior thyroid horn. So sagittally, when we did a MIP image here, you can see the hyoid bone, you can see the superior horn of the thyroid cartilage, and on many scans, you'll see a rounded radiopacity. It's not a carotid plaque. It's a normal structure we visited last week called the triticious cartilage. I've never seen any pathology with it, but it kind of looks like an opacity. You can imagine what it looks like on thin section. You kind of get confused. So now that you know what it is, you shouldn't get confused. One of the things I wanted to point out was, if we came laterally, the condyle would be right about here, okay? This is actually medial to this condyle, and this is the internal carotid artery. And it's not only coming up here, it's gonna bend forward and go up again. I find plaques within the carotid artery, just scrolling through these sagittal views. I also find MAC, the medial arterial calcification. You can see this looks much different. This is the internal carotid going through temporal bone, okay, and then sphenoid bone rather, and then it's going to curve and come around here. So if you see parallel lines in this kind of region, this is sphenoid sinus, adjacent to the sella, it is medial arterial calcification, and you're looking at MAC. So there's the path of the artery that it takes. Internal carotid comes up there. You're going to see it, you just hadn't recognized it until now. All right, coronal sections. Simple ones for you. This is the parietal bone, or could be part of the frontal bone because we're anterior enough. B is actually the crista galli. It ties down the 2 halves of the brain structure or matter. C is an ethmoid air cell. D is just pointing to the maxillary sinus. E is pointing to, actually that didn't quite hit it. It's actually pointing to the mental foramen, but I kind of missed it there. And you can see that this poor young lad has a deviated septum. He has concha bullosa in the middle turbinate. He has some mucosal change in the ethmoid air cell complex. And this area going off here, the radiolucency, is the lateral recess of the frontal sinus. So if this is blocked, the ostium into the maxillary sinus, and you can't get stuff out, this inflammatory change will lead to other change because the stuff cannot drain. So in this particular plane of section, we're back a little bit further. A is the lateral wall of the orbit. B is just an ethmoid air cell. C is the middle turbinate on the patient's left side. D is pointing to the common meatus. There's inferior meatal space, middle meatal space, superior meatal space, and one that's common to them all, running along the side of the septum. And the septum in this case is deviated. E is the zygoma, F is hard palate, G is pointing to the inferior alveolar nerve. A little higher up, more anterior, we can see the optic nerve. We can see the superior orbital rim up here. This is the masseter muscle A. B is the inferior turbinate, and you can see it's much smaller than the one on the left. So in this case, we would report the left inferior turbinate is hyperplastic relative to the right and has narrowed the adjacent meatal spaces. They may have a breathing problem on that side. G is just a torus, F is the sinus. And those you can disclose when you come back and revisit this, because I know we're going fast. You know, Jim warned me, he said, you know, an hour to do all those slides, that's pretty tough to go. So we may go just a few minutes over, but not much. Important plane of section to look at. When we get back to the sphenoid sinus, I'm going to label these things. This area right here is actually the optic canal. It sits within the clinoid process region. This is where they cross. So that's optic canal. This is the anterior clinoid process. This area, this rounded area here and here, is the foramen rotundum. The one just below it right here is actually the Vidian canal. So just to show you that this is a conventional CT scan, unenhanced, no contrast, and you can see the same structures labeled. So I always verify the structures that I find in cone beam. Notice the resolution and detail is much better in our thin slice cone beam than in this conventional CT. But of course, they're looking for other things in here. So my sort of advice to you is pay attention to the region around the sphenoid sinus and sella turcica. On here, the clinoid processes are here and here, and this loop, this loop, this loop, and this little bit of opacity here, when we thicken it out, is actually the internal carotid artery in the cavernous and ophthalmic segments curving, okay? And when we do a MIP image of those same areas, you can see how circular they look. These are not plaques, okay? These are medial arterial calcification. Now, the yellow arrow is pointing to a valley, the foramen ovale. I'm going to show you, this is with contrast. This is why we see the vessels. This was a court case that I was involved in and took it into the software and made fancy images. The styloid process on the patient's right or left, it always passes between, the ligament passes between the external and internal carotid artery. So you can actually have a second type of Eagles where this impinges on the arterial wall and you get referred symptoms. When the internal artery comes up, it curves medially and goes up through, this is called the foramen lacerum, and this is what runs in the lateral wall of the sphenoid sinus. So just really nice example of these structures for you. And you can see it here, this is medial to the condylar head. There's a bit of the external, this is probably internal auditory canal, but you can see it come up, go forward, bend again right at the cella and go up again. So this is where I see the calcifications in all different planes of section. There's your rest of your mandible outlined. And this is what they'd look like. Again, parallel lines, that's MAC. I did the maximum intensity projection to make them stand out more, and they were referred for a diabetic workup. There's a valley, there's the nerve, fifth cranial nerve. And I think what we'll do is we'll just stop here. Let me just see which I'm on. Yeah, I've got 8 or 10 slides to go. Maybe you could poll the audience and ask them, should I go on for a few more minutes or should I just stop there?
Sounds good, doctor. Let me do that poll. This is Jim. Let me do that poll, and everyone's saying keep going.
Okay.
coming in. So
All right. I
that's
apologize for being so long-winded. I didn't even tell many anecdotes today, but here I am. Okay.
uh,
Let's just fly through this. 1 is hard palate. 2 is actually pointing to the inferior turbinate on the left. 3 is pointing to the middle turbinate on the right. 4 is actually pointing to the maxillary sinus. 5, nasal septum. These are pretty straightforward. 6 is pointing to the zygoma. 7 is pointing to the frontal bone. And this suture in between is zygomatical frontal suture, not zygomatical temporal suture. So there are other sutures to look at. They're not fractures. 8 is the cristic alley. 9 is the lateral recess of the frontal sinus. 10 I don't expect anybody to get, but this little thin bone protrusion here is the uncinate process. And when the ENT docs go in to do their scope of the sinus, they'll go in the nose. They often fracture this so that they can get a peek into the sinus and do their functional endoscopic sinus surgery in that region. So it's a good anatomic structure to know, but it has no, I've never seen pathology with it. Ethmoid bulla just means an enlarged ethmoid air cell. So that was what the last arrow was pointing to. This is a little bit simpler. 1 is sinus, 2 is nasal septum, and then we're pointing to the common meatal space again. So just to the right of the septum. 3 is the inferior alveolar nerve canal. 4, inferior turbinate. 5, middle turbinate. And very nice example of 6. Very rarely do you see these superior turbinates. They're so small. They're not like in Netter's anatomy books, but this is a real nice example of that. So that's the superior, inferior, middle, superior. And this is just pointing to an ethmoid air cell. This was such a nice structure that I put it in the Scanatomy app, and this is one of the screens you get. It says the structured label number 12. You find number 12. You push on, you push on the button, and it tells you what it is. And if you're correct, it's green. If you're not, it's red. And it's a real nice way of learning that anatomy. So here are structures that we've already reviewed, and what I'm going to do is go over them real quickly, and then I'll be pretty close to being done. A is the lateral pterygoid plate. B is the Vidian canal. C is the sphenoid sinus. D is the anterior clinoid process, optic canals being right in here, carotid artery here and here. E is the foramen rotundum. F is zygoma. G, of course, is part of the hyoid. Now, this is all labeled, so you could quickly review this when you go back to the Vatech site and spend a little bit more time on some of these screens, memorizing them. There is a site, I won't show you this video, it's from the Visible Man Project, and basically it's you can scroll through and actually see dissections. I stopped here because this is what we're dealing with. We're actually got a slab through this dissected body, and this is the internal carotid artery on each side and the sphenoid sinus. So very difficult to see these structures with all the soft tissue, but of course they can see it in MR that way. So they can also look at these diabetic possible candidates with conventional CT and MR. All right. So small volume anatomy I'm not going to do. I will stop here and show you this one though, because this explains a lot. If you have a small field of view and you're looking at a condyle, this is the internal carotid artery. If we follow how it its path towards the sphenoid bone, you can see it's starting to open up here. It opens up more here, and you can see the entire length of the canal. Still seeing the condylar head. Sometimes this wall will dehiss, and the carotid artery will get, you'll hear pulsation, or patient will say, I hear whooshing sounds. So this is an important region for everybody to look at if there's capturing condyles. And then I have the artery mapped out for you in there. This is from the textbook showing not these white labels, I have better labels, but showing a slab running of condyle, carotid artery, the canal forward, and the sphenoid sinus. Skip this one and skip this one. So to finish up, this is a typical panel of images that you would see for axial. I think there's actually 12 of these, and you click on the particular plane of section, it takes you to the next page, and you just identify the structures. And if you go through it one time, all the screens in axial, sagittal, coronal, you'll probably the first time around get 30 or 40% correct. By the fourth or fifth time, because when you restart it scrambles these answers, you will be an expert or getting close to it to know your anatomy. So there's more information on all of this on my website, drcombbeam.com. I want to thank Vatech for allowing me to do this. I got one more screen to show, so I want to thank also the Horizon Dental Institute, Dr. Tom McClammy, and this institute for allowing me to use this facility and being the group that awards your 1 hour CE credit. So we'll share that webcam and we'll open up for questions. Thank you guys, appreciate it. Sorry I went a little overtime today.
No, Doctor, thank you. Everyone's a lot of information to cover, and everyone's been very interactive on questions. Paul, I think you've got some questions on there.
Yeah, I do. Thank you, Dr. Miles. That was great. I'm going to start with a couple that several people have been asking. First here, where are these images, these data sets coming from in the presentation?
Oh, that's a good question. It's all patients that have been referred to me in my reporting service. So these are from any type of machine, any size field of view from I have about 140 clients that some send a few cases every month and some send a lot of cases every month. So when I see these, I actually capture them and then put them in PowerPoint and label them up.
Okay, got it. Is there a scan size that is ideal? Also adding, I don't know that I need or want to see this much anatomy. And then also, what about the dose to the patient to see all of this?
Okay, where do I begin? Most people get real nervous having to relearn things, but unfortunately you didn't cut your first class 2 cavity prep perfect the first time you did it. So reviewing your scans, you will learn the anatomy. I wouldn't worry about the field of view. There is no ideal one. I would select a machine like out of the Vatech family that allows you to pick a different size field of view depending on your task. So for something like implant planning, you might think I only need a small field of view. But last week I was reminding people that if the patient has a problem on their condyle, a little spur, some osteoarthritic change, you change their bite on the opposite side, they might come back to you in 2 weeks and say, Doc, I can chew great, but how'd you make my joint hurt? Okay, so you really are treating the patient. You're not just providing, one sort of task that they ask for, their implant or the root canal. I would not worry about the size of the field of view. I would get what you think will cover all those bases that you want to cover, because there's lots of applications for a medium to large size field of view that you may not even thought about. A lot of people buy a small one, especially endodontists. They're now going to a larger field of view because patient comes in with a problem on their lower right, but oh, guess what? There's also something on the upper left. Well, if you have too small a field of view, you got to take two data sets. As far as dose goes, I think we worry way too much about dose with cone beam CT. Dose in all the machines ranges from about 12 microsieverts to about 120. Okay, a medical conventional CT of the head to do implant case, which they used to do in the past, is 2,100 microsieverts. So the dose that we're talking is extremely low. The patient is the one you're trying to serve. If they have something in your diagnostic evaluation that says, I would get some useful information for treating this patient out of this cone beam scan, take the scan. I don't even worry about dose. Okay, I may run afoul of some of my other radiology colleagues, but we get 3,600 microsieverts walking around the planet from ingesting radon, being exposed to it, cameras, televisions, planetary isotopes, or planetary particles flying through space. We get much more dose you can't even separate out the low dose of CBCT to from those other naturally occurring radiation problems. Right?
Great, thank you so much for that.
Long-winded.
No, it was great. It was great. Lots of questions coming in. Here's one. And Jim, you might be able to add something on this too for webinars for the future. But do you have a course, in parentheses, easier to explain CBCT for staff?
You're going to answer first, Jim, or me?
So my interpretation of that is just like you talked about with doctors looking and recognizing. I can attest to what we do at Vatech is when one of our users gets a device, we work with the doctors and staff in several layers. So it's not just one and done, like, oh, here's your 2 hours, learn it, watch a video. We have several touches because the repetition I find when the staff are using the device, and even some doctors we did a poll last week, that's one we talked about, where the doctor's like, I want my staff to be involved. Internally, Vatech, we have that process that we'll go through and teach our doctors and staff and to new staff members, not only how to capture a proper image or without movement, or how to deal with difficult patients. If we have older patients may have shakes or tremors, or young kids or larger patients, but also how to, and then where are we going to take that image and either export it out to radiologists, look through it and be able to talk to our patients and integrate that into their practice, especially with going back. Doctor, you talked about larger field of view. We want to be able to look at that whole field of view and prepare our clients for that. So that's kind of what we do in-house. I know there are other options out there of series on this, and you and I even talked about that, of doing your weekly webinars here. We had to start at the basics somewhere. We had to start 2D to 3D. What are we seeing? We had to look at anatomy today, and then you've got several more courses that we were looking into working together on doing, of how to identify endo. You talked about how do we look for pathology in certain areas. It's just so much information there on there. So that's my long-winded answer.
Okay, well, I'll add to your long-winded answer. I don't specifically have a course for staff members, assistants, or hygienists, or even office managers, but a lot of them come to the courses that I present. And unlike these webinars, which I think is a very useful way to deliver content, but needs to be followed up by repetition, revisiting your site and going over this again. You can't teach cone beam in an hour. You can't even teach it in a full day. It takes me 2.5 days normally in a program when I'm doing it. And those who come get a very replete experience. They are taken through principles, applications, risk and liability, anatomy, all of the things that we see in the scan, and basically how to create a report at the end. So that type of content, you can't master it in this 1 hour webinar that I kind of fired through. You can't learn your anatomy or your pathology vicariously. You can learn to recognize that does not look normal. We better do something about it. And that's where I think the staff probably, as in any dental office, they are another pair of eyes. Doctor, look at this. This doesn't look like I've been taught or I've seen on other scans. What do you think it is? So I think they would get, even with more limited background in anatomy, in some cases, they would still get a lot out of these webinars by going back and visiting them. So I would encourage the doctors to review this one, for instance, in their office with their staff. Okay, I think that would be a great way to, it's there for them. All they do is register and away they go,
Right.
We've also, Dr. Dew, we're kind of the company philosophy is we want to build a relationship with our patients, just like you're talking about the doctors that you read cone beams with. You've got a relationship with them. We as a company want to build a relationship with our doctors, so they can call us up and say, hey, I need a refresher course, or I have some staff members who are having some troubles. They have access to us as an education team, our sales guys, and our CS, and overall, I think it's a lot of this is about building relationships and being open to provide that service for learning all around, educating.
Yep, absolutely.
So here's a great question to follow up on that topic. When will Dr. Miles resume his 2-day seminars, and where are they presented?
Well, the first seminars that I'm doing are in Johannesburg and Cape Town, South Africa in August. And I don't think many people will want to pay to come there to see them, but that's the next set. I do one also still scheduled at the California Dental Association in, I think it's September if it still goes through. And I'm doing one at the University of Toronto, the 2.5-day program at the University of Toronto, because the doctors, the poor doctors in Ontario, Canada, have to have 30 hours of university-based CE and cone beam before they can even get a certificate to allow them to buy a machine. So it's always a very well-attended course. There may be others. Go to drconebeam.com. I usually have my schedule posted up there so they can see others. But the first 6 this year were all canceled and rescheduled, or some rescheduled. So unfortunately, yeah.
Right. Another question about the app. So the app is Scanatomy, and it's only available for iPhone, correct?
Unfortunately, if there's anybody out there that's can program Droid and the other devices, contact me at miles.dale@gmail.com and we'll work something out, because I'd love to have it be available in the other format. But the guy that did it for me, a young friend, he's a Mac guy, all you Mac guys out there.
There was a question here about when you're viewing your scans, what slice thickness do you prefer?
Yeah, that I do a whole, and we're talking about this webinar at some point. I do a whole hour on how to review a scan and sort of a protocol and approach to it. And there is no ideal slice thickness. I look in the thinnest plane of section, but I only look in one plane of section at a time. So I'll go through all the coronals or all the axials. And if I see something unusual, of course, I'll switch out to another plane, maybe make a MIP image, maybe make a surface rendered image, convince myself that, yeah, that's really the problem that I'm seeing. But to do that takes me around maybe 5 to 12 minutes to review a scan, capture images, and then it takes me another 15 minutes to put the report together. So there's a lot of time and effort spent on creating the report. So the thickness is, there's no ideal one. You're going to start in thin slice all the time, but you have to be able to understand the 3 planes of section and when you need to apply some of the tools that are in your software in order to get more out of that image to help confirm your diagnosis.
Well said. Well said. Here's a question. Do you recommend referring if inflammation is seen on a nasal turbinate and to a GP?
Yeah, okay. You'll see thickening around the turbinate sometimes. You'll see inflammatory change in that anomaly that we call concha bullosa. If you just see mucosal change, just a graying area, and the patient is totally asymptomatic, I wouldn't refer them at that point. I probably would do a periodic radiographic evaluation. Of course, I'd ask some questions related to the finding that they saw in the scan. And if there was no symptomology, I wouldn't worry about it. Okay. If they are symptomatic, or they hold one nostril, they go to breathe, and they go, yeah, I can breathe, and they do this when they go, they can't breathe. Obviously, there's a sign. Okay, and you might want to have a referral back to the primary care provider, or sometimes straight to a otolaryngologist, an ENT doc, especially if they're having breathing problems, or you see other mucosal change in the paranasal sinuses or ethmoid air cells. So it all depends on the amount of change, whether the ostium's blocked, just like I talked about last week. So I do a whole, paranasal sinuses and nasal cavity is a huge section of when I talk about applications, because dentists are expert with the maxillary sinus because of PANS and PAs, but you start extending into the other areas, they have a lot of learning to do still.
Right. Here's a follow-up to kind of that idea. Are we responsible for all abnormalities? And are we responsible to know all the abnormal structures?
Well, there aren't any abnormal structures. Abnormal structures are called anomalies. So yeah, if you're going to have a scan, you should know what the common anomalies are. But you're responsible for everything in the scan. There's no way of abrogating that responsibility. If you take a scan, you're responsible for what's in it. Same when you take a panoramic. And on occasion, people will see something on a pan and go, I don't know what that is. It's an I don't know-ma. Remember we called it an I don't know-ma? Well, you refer it. That's the standard of care. You don't have, there's a distinction. You don't have to diagnose everything that's in a scan, okay? But you have to look. And if you have to look, you have to be able to recognize this is normal, this is abnormal. Abnormal, I need another pair of eyes on it. I need an expert with more, skill than I do to look at it. So yeah, if you take a scan, you're responsible for everything in it. That's the whole risk and liability lecture,
Yes. Here's a great question. Is there a standard of care in the U.S. for recording or analysis of CBCT in patient records?
There isn't. Okay. There should be a professional and ethical responsibility on the part of the dentist or dental specialist when they see something in a scan that's noteworthy to at least make a chart note. But in the US, there's no requirement for a formal, report. The structured report that we get out of that software that I introduced last week called EasyWriter, that is a requirement, a structured report in many provinces in Canada now, and several states are looking at a comparable, protocol, but no one has adopted that yet. So, standard of care is a strange thing. If I practice in a rural area in Montana, it might be slightly different than, a large metropolitan center. However, that's changing because internet availability of educational programs, even like this, okay, the webinars, means that, well, doc, shouldn't you have known that? Well, in these days, the answer is probably, yeah, I should have known that. But hope I answered that question.
For sure.
So I got a couple questions about monitor sizes. Somebody had asked is there a benefit to using a medical grade radiological monitor, or will a 4K or 8K high res monitor be a reasonable substitute for medical grade quality?
Yeah, that's a great question. I don't even use a medical grade monitor. Okay, you want a monitor, and most of them meet all the requirements that we need with high spatial resolution and a long scale of contrast capability and a good brightness. But most monitors, 17-inch or larger, that are good graphics cards and capability and the brightness level, like the lumens. Most monitors will suffice to look at. When you say, is there an advantage? Of course there's an advantage, but advantages for a medical grade monitor, I don't think dentists realize this. A medical grade monitor in medicine may be a monochrome, maybe a monochrome monitor with 14 or 16-bit capability, being able to show even many more shades of gray. Why? Well, because in CT and MR, they get every point in the scan of the patient, every point of every tissue, so they can separate fat from blood from, what I mean? They have much higher capability. Our requirements are more for spatial resolution, smaller the voxel size because the capture is different. These little cubes, the smaller the cube, the higher the spatial resolution. When you go to a smaller voxel size and higher spatial resolution, sometimes you increase the dose, and people worry about that as well. So there's no simple answer to that. If I were a medical radiologist, if I were a neuroradiologist, I guarantee you I would have and they actually specify the ACR and the RSNA specify monitor specs that you must have, like in a hospital environment or radiology setting. But for our needs, because it's just high spatial resolution and filters or tools to get more clinical information out of the scan. Just a pretty high grade, commercial, public commercial monitor would be just fine.
Great. Yeah, I think we get that question a lot as trainers in offices, 'cause
Yeah.
whether it's a TV or a monitor, so we do get that question quite a lot. So thank you for
Well,
that.
let me expand on that just a touch. And this is a holdover from all my digital days way back in the late 80s and early 90s. People expect that a monitor that they buy at Walmart, Kmart, wherever, Best Buy for $2.99 will show real good resolution in color. In color, it does, but in grayscale, most monitors only display 8-bit information, which is 256 shades of gray. That's it. So they buy this monitor. Oh, I bought cheap, and look at my clinical images look great. I can see all these. Yeah, because those little boxes called pixels that you put the grayscale in, when you have color to put in there, you've got 50 shades of pink and 50 shades of blue and 50 shades of green. You got a lot of combinations, so you get a good color image. But in a small pixel that you can only put one of 256 shades of gray, that makes a big difference. The grayscale images don't look nearly as nice as if you had a big medical grade monitor with higher, bit level or bit depth for grayscale as well, because they have to separate those things. They're looking for small changes.
Great. Thank you so much for answering that question.
Yeah.
Jim, do you have anything to add here?
Yeah, well, I think we had one last question about patient movement, doctor, and what to do if the patient moves. I know that greatly affects the image quality or the result of the image. And sometimes we get images that the doctor, hey, can you help me, trace a nerve or look at this, and it's impossible. So we work with our staff members to identify, hey, this patient moved. We watch the patient when we scan them. What are thoughts on patient movement? Do we just have to scan them again?
Strap them down.
Right. Any way to get them home, right?
If you can stabilize chin, forehead, chin, temples, and forehead somehow to minimize the movement or eliminate the movement, you'll be much better off. But movement will kill a scan. In one of the references, I didn't put it in this one, but in the Dental Clinics of North America 2014 volume, Bob Danforth and I were the co-editors, and there was a friend of mine, Scott Makins, who's a endodontist / radiologist or maxillofacial radiologist, did a great chapter on the artifacts, that occur in CBCT scans. I think it's available for free download off the Elsevier website. You can get there by following links on Dr. Combing, but it explains all of the different errors, because there's many more than movement, but movement is tough. Movement, I see it all the time, and sometimes you just have to bite the bullet and tell the patient we've got to rescan you because there's too much movement. Dr. McClammy's assistant had one this week. He was a 87-year-old man who they had to do a scan where there's a one pass and then there's a little change of position and then a second pass, and they stitch it together. Well, he talked through the entire image capture. They ended up taking 3 scans, and between the 3 sets of data, I could actually get all the findings, but
Right.
some of the images were terrible. So minimize or eliminate movement if at all possible. Yeah.
Perfect. Well, doctor, thank you for today. People have been asking about your Easy Rider app, and I have that coming up on screen right there. Easy Rider and Scanatomy. Those will both be in our follow-up email to everybody. We really want to thank you for your time with us these past 2 weeks, and look forward to additional sessions of working with you, Dr. Miles. Thank you again from the Vatech family very much.
As they say these days, you're welcome, brother.
A couple other things we talked about next week, directly to some of the questions that we had for you of how do I involve my staff. We're going to highlight what we're doing next week. Complete health dentistry, a paradigm shift involving your staff. Gary Cady is going to be coming on, author of $1 Million Dentistry. we're going to bring on one of my doctors here in St. Louis, Dr. Lisa McDonald, to talk about cone beam technology in her practice. Also, next level practice with her. All the webinars, Dr. You mentioned being able to follow up with these series. We have them on our website, vatechamerica.com. Go to Learning Center webinar. Everyone's going to get an email with a link, technical support. And then lastly, we'll follow up with everybody next week with your CE form. So if you were registered for this, you will get a CE form for our US residents. And we really want to thank everybody from the Vatech family to everyone who's joined us this week. Dr. Miles, thank you. Dr. McClammy's office for allowing you to go over to the Horizon Center. Thank you, everyone. And we look forward to the next 2 weeks of our Wednesday webinar series. Thanks again,
for having
Paul.
me.
Thank you so
Stay
much.
healthy, guys.
You too. Thank you. It's a pleasure.